Looks like it's been a long day for both of us. You wanted to talk a little bit about your heart health. Yeah, that sounds good. Let me ask a few questions first, okay? And then we'll do a little cardiac exam. Okay? Absolutely. Yes, so I'm talking quietly because I am an actual physician, but I want to keep all of our secret medical information just between you and me, so the other, all these evil doctors who don't want to share their secrets with you don't catch me. Just kidding. So I am a physician in real life. In this, world between worlds where you and I are, I can't give you any official medical advice for diagnosis or treatment because you and I have never met, right? And everybody's individual situation is different. But I think you're going to get a lot of good self-care and maybe a little relaxation out of it. Absolutely. So let's talk heart health. Talk heart health. Talk heart health. Let's talk heart health. Okay? So when you go to your primary care physician, they really should be the one who's taking care of your heart the most. Really, you only go to a cardiologist for unique procedures usually. So for example, if you need what's called a catheterization, where they go down into your femoral artery and they put a little metal, it's almost like a metal string, a wire that goes through your veins all the way up to your heart to knock blockage out of the way. So your PCM or your generalist should be really experienced with most heart health stuff. That's a specialized surgery that, you don't need. And yeah, a cardiologist can do that. An interventional cardiologist doesn't have to be a cardiothoracic surgeon. What else does a cardiologist do? Well, so a cardiologist is also going to, when the generalist can't figure out a specific thing about a murmur, usually they'll send you to a cardiologist. So if you have a special murmur that indicates that there might be something off with the shape or one of the pieces of your heart, then they'll send you to a cardiologist to see if you need another piece in. Your internal medicine physician also has a lot of experience with heart health and should be able to take care of most things, but for 1 or 2 visits, they'll probably send you to a cardiologist just to make sure that kind of murmur doesn't need a surgery and that it can just be managed medications-wise and so forth. So a cardiologist has done about 4 extra years of training after their internal medicine training, which is already 4 years. And your generalist, it can vary. Some of your generalists, like me, I did 1 year of family practice, and then I did operational medicine after my medical school, right? Medical school is 4 years. Everyone learns basic heart health in medical school. So I'm at the very low end of that. On the other side, you might have a family practice person who's done 3 years after medical school of all kinds of different special residency stuff. And then, like I said, internal medicine 3 or 4 years, and then the cardiologist has done the 8. So that's why we reserve cardiologists are rare, because they're, they've done all that training. So cardiologists, we reserve their expertise for times when, and they'll be very expensive for that reason as well. We reserve their expertise for times when your generalist can't take care of it. Because again, the basic heart health, everybody learns that in medical school. Everybody should know, your detailed exams, and they should be able to take care of the things that the cardiologist tells them about. So a lot of times the cardiologist will start your care and then send you back to your generalist to manage everything. The big benefit to you with that is the cardiologist just takes care of one system, your heart. You might also have a nephrologist who's taking care of your kidneys. You might also have somebody taking care of your IBS for your belly. Well, who's going to make sure that all those medications are in interaction with each other? Who's going to make sure that every little piece, for you to make sure that you're okay, is together in the right place, and that people aren't overlapping, that there's nothing being missed? Because if you look only at one system, what about disorders that affect the entire body, right? What about the interplay of the psychological into all those different things, right? And that's what your PCM, your primary care provider, is supposed to do. There's a lot of evidence through recent studies with AFP and other organizations that find that you tend to have more You tend to have decreased costs if you have a better relationship with your PCM, because they can decrease costs for you by making sure that you have all the pieces all together, right? Specialists tend to miss things because you're going so deep down one rabbit hole, you don't get everything. So, obviously the ideal would be to have like the old days doctor with the black bag, right? Who can come to your house and take care of you. That would be the ideal. And then, you know, when they need help, they call your specialist, but they have enough experience and information that they can take care of you themselves, right? That would be the ideal for most people. Absolutely. All right, so that's kind of what a cardiologist does, just to give you some information. What symptoms have you been having that have made you concerned? Okay. Tell me about this. Tell me about the chest pain. Where's the chest pain located? Can you point to it with just one finger? Okay. That's actually really reassuring. How long does it last? How often is it? Any pain now? No? Okay. Oh, it's been going on a few months. Did you have any kind of event beforehand? Did you have a cold, or were you in a fight? Did you have some kind of like deep exertional activity? Did you start a new workout regime? The reason I asked that, give me a second and I'll push on your chest real quick. Okay. Hold on. Right here. Right in that spot. Point to where it hurts. Okay. Yeah, and that hurts when I push down there. Okay. Have you been having any episodes of dizziness or fainting? So dizziness is different than lightheadedness. When I talk about dizziness, I mean like vertigo, where the whole room is like spinning around you, right? And everything is like you're drunk on a pirate ship. Yeah. And when I talk about lightheadedness, I mean like, you know, like it really is the perfect word, because it's like the top of your head, it's like light, and like you almost feel like darkness is going to come over you and you're going to faint. You have to sit down because it feels like you are off steady, like you feel weak. Not that the world around you is spinning, but like you feel weak and just can't, you know. And like you might, and not just weak, like physical weakness, like body weakness. I mean like it's like your brain is about to like go, because it's like when you stand up really fast, that kind of lightheadedness, that's called orthostatic hypotension. I mean that, but without the trigger of standing up really fast. Do you have that? Okay. Just randomly is what I'm talking about. Or I'm talking about worse after exercise, where you exercise and then you have that same feeling. And not when you're like dehydrated, not like that, not like, oh, I'm kind of lightheaded because I've been, you know, I've been exercising so hard. I just ran 5 miles and not like that. How about when you're just walking? I mean, like you start walking and then all of a sudden you feel lightheaded. Like you might pass out. Have you had any episodes of actually passing out? Any palpitations? Okay. So the reason I ask those things is those things with chest pain can be concerning for a cardiac. Specifically, if you have a really strong crushing chest pain, you shouldn't be here. You should be over at the ER. If you have a strong crushing chest pain that radiates down your left arm, up your neck, to your jaw, and it feels like something's sitting on you, and it's general, you can't point to where it is, it's like a big thing, just crushing up in here. And not like a tightness, not like tight and you can't breathe, but like heavy and you can't breathe. That's what I'm talking about, big crushing chest pain with some kind of palpitations. The lightheadedness is a big thing. A big red flag with this crushing chest pain is if it gets worse while you walk. You start to walk and it gets worse. You stop and it gets a little better. You sit down, it gets a little better. Obviously, it's very bad if it continues through all those phases. Like it's still really bad when you're sitting. but you know, when you're walking, it gets worse. Exertion makes it worse in the moment is a big, please go to the ER kind of red flag. So with that kind of chest pain, so that's the chest pain that's more, that kind of thing makes me worry more about either a severe like hypertensive urgency, or that makes me worry more about a heart attack more than that, right? If somebody has all of those symptoms, right? And it's not just, because you can have a chest pain that feels a little bit like a pressure, like a squeezing, especially when you have pneumonia, when you have one of the new viruses that are going around, right? So those kind of things. But that's different because that's over a long period of time, you know, a couple days, a couple weeks. Maybe you cough and it's sharp in one section, or it feels like squeezing, it hurts when you breathe. Those are all make me think more pulmonary. But the things that make me think more cardiac, more like angina, more like MI, myocardial infarction, are that crushing radiating to the neck, the jaw, the arm. And the big thing is that, you know, it gets worse or better with nitroglycerin. That's one of the Diamond Forrester criteria. Or it gets worse or better with exertion. Those are the things that kind of, you know, concern me. There's something called a heart score, which you can look up, that kind of goes through some of that. So, and those are things that obviously pneumonia might concern me too, depending on the severity of it. You might have some nausea with you know, cardiac chest pain like that. You might have some difficulty breathing just because of how heavy it is, right? But the difficulty breathing is not the primary complaint. The primary complaint is this heavy chest pain that changes when you walk. And you're talking about like a few minutes onset, like, or a very sudden onset, right? You're not talking about days. You're talking about, you know, a couple of minutes and then maybe lasting 20, 30 minutes, you know, probably not, hopefully not gonna last an hour, but, and then, you know, lasting. Yeah, I can show you. Here. I like to go behind the scenes for you guys for medical stuff. This is the pocket handbook that a lot of, you got a little something on your face there, I'm sorry. There you go. Yeah, I washed my hands before I came in. Right at the door. So, pocket primary care, or I have a pocket internal medicine too. These are the handbooks that we use when we are starting out as physicians after medical school, and they have long sections on cardiology, and I can show you. For example. So if you're curious about medical stuff, don't go to WebMD. I'm not saying to go to WebMD. I'm saying you can certainly take a look at some of these things. So like ACS is going to be here, chapter 1.6. If you want to look at stuff that's not Dr. Google, this is what we look at. This is the kind of stuff that we look up when we're trying to educate ourselves. We don't go to WebMD. So don't go to WebMD. But just so you can see behind the scenes, right? And it goes through, you know, we've got the little EKG charts, basically to show us the difference between a STEMI and an N-STEMI. That's when I get you an EKG. That's the reason we get an EKG, is because the way that the electricity in your heart changes during a heart attack, I can see it on an EKG for certain kind of heart attack, for the most dangerous kind of heart attack, which is called a STEMI. And it's called that because this part of your ST segment here, which is this segment, is elevated, versus here, see how they're not. This is actually a depression. So neither of these are normal. I do have a picture here of a normal one for you. I don't know that I do. Here we go, here's a normal one. Well, with a bundle branch block. Oh no, that's a normal here. So there's a normal one. See that? The second one is probably the easiest for you to identify. That's in a different lead, and that can be confusing to people who've never seen EKG before, but right here. So that's a normal one. And V6 or V2 looks like that normally. And then see how that segment is down? That's an ST segment depression. And then see how this little bump in this part, it's upside down, an upside down bump. That's called a T-wave inversion. Those are also things we look for in case of heart attacks. So I'm really glad that I have these pictures to show you. So when you have those kind of symptoms, that's why we send you to the ER and you get an EKG so we can see that. And we also get something called troponins, which is it's a little enzyme that we draw from your blood that is the byproduct of, if you're, how do I explain this simply? It's a byproduct of muscle breakdown, but it's specifically the byproduct of cardiac muscle breakdown. When a normal muscle breaks down, it releases something called CKMB, and sometimes when we can't afford troponins, we might get a CKMB instead and see how those are breaking down. But those don't elevate right away in a heart attack the way that well, that's not true. The timing is a separate issue. Those are not cardiac specific. That's the most important thing. The most important thing is that troponins are specific to your heart breaking down. CKMB is a muscular breakdown, more generally. So that's why we look for those. We look to see, are these troponins up? Because that means the heart muscle could be breaking down, right? So those are things we get. So, but I wanted to show you, I think I actually mentioned all these things already, because this is something that I used to deal with a lot. I used to see a lot of people who were there for what's called an ACS rule out. Oh, one I didn't mention is diaphoresis. That's sweating. That's sweating. Now, some people might not have the typical symptoms. Some people may have this weird sense. So again, going back over those big kind of scary heart attack symptoms, crushing pain radiating to the jaw, to the left, to the left arm, which, that's your left. This is, this is my left. Radiating to the jaw, radiating down to the left arm. I actually had a child patient who had one of these, a 14-year-old actually, at one point, which is incredibly rare, but it happened. And with that crushing pain, you might have some nausea, you might have a ton of sweating, right? You might have what's called a sense of doom. In diabetics and women, sometimes the pain will be here in the middle instead of up here. And sometimes diabetics won't feel it at all, right? So always have a low threshold of suspicion for going to the ER for a suspected heart attack. Things that are reassuring and that indicate not likely to be a heart attack, right? These are the things that I want to go over with you today, since you don't have those other symptoms. One of them being, if you can point your finger to where the pain is, that's not a heart attack, okay? Point your finger to where the pain is, and it's a sharp pain, that's more likely to be what you have, which is costochondritis. And I know that because when I pushed on your chest, it hurt, and because of when it started. If it, started a couple days and you just keep having it, every now and then you get that really sharp pain, it can be really painful, it can be really terrible. But every now and then you just get that pain. And it started, sometimes after a cold, sometimes after a big exertional event, something like that. And sometimes you might not know what the trigger was. Real common in young people. I get it a lot. Common in people with inflammatory disorders as well. Just a really nasty, sharp chest pain. You can point to where the pain is. That's costochondritis. Now, of course, if you had a trauma, you were fighting with someone, and you can point, it may be a broken rib. That's if you, it hurts when you breathe, and you would know. That's a different kind of pain. Okay. I've had those too. Not in myself, but those patients, have chest pain because they were, roughhousing soldiers, It can be like that. And what else? Other reassuring factors that indicate that it might be pulmonary instead of cardiac in origin is it started over a couple days, a day. It's worse when you breathe. It's worse when you cough. Now remember I said with the cardiac chest pain, you might have dyspnea. You might have difficulty breathing, right? But it's not the breathing that hurts you. There's another pain and it feels crushing, and that makes it hard to breathe because you're having this chest pain, right? With the dyspnea of a pulmonary problem, I'm saying every time you breathe, oh, there's like a sharp pain somewhere, or it just it hurts to breathe and you just want to take little tiny breaths, right? And that's because you might have bacteria, trying to eat up the sides of your lungs and things like that. And there's a lot of gunk and inflammation there. And so when they move, that hurts, or your chest wall might hurt from coughing so much. Yep. So those are kind of chest pains. After you've had an event where like an ACS rule out, right? Where you had to go to the hospital because you had some kind of cardiac chest pain, but you didn't have a heart attack. You didn't have a STEMI or NSTEMI, but they think there's something wrong, some blockage in your arteries, right? Anyway, because you can be having cardiac chest pain without blockage in your arteries, right? And that's where you have all those symptoms. It's very cardiac. You have, a previous diagnosis, maybe of hypertension, diabetes. We start adding up your score and it looks more and more cardiac. And then you may have had a negative EKG, negative troponins, but you had those symptoms. Maybe we keep you in the hospital overnight for observation on a telly to make sure you don't end up having a heart attack. We watch your blood pressure. Maybe we modify your blood pressure medications, right? And then we do what's called a stress test, right? Where we have you do exercise so that we can figure out, okay, I think that this is a coronary artery problem, right? But they don't have enough blockage to be having, full-on heart attacks, right? But it does seem like they have some blockage. Let's see if we can find where it is, and if it does exist, right? And what they do is they have you exercise to stress your heart to find where exactly, what part of the heart you could possibly have a blockage or a problem in. And that's more to see, what stage of risk you're at. And once we calculate what stage of risk you're at, we might send you, it might be severe enough that's like, oh, we can't finish this test. You need to go see a cardiologist so they can see if they need to unblock something, right? Or it might be that you're at a low enough stage of risk that your internal medicine, family medicine, your generalist can manage you, right? It depends. Okay, so that's kind of some of the big things we're thinking when you go to the hospital with, severe chest pain. So that's kind of do you have any history like that? Okay, good. I know, lots of long stuff. Anxiety can cause a really severe chest pain too. And you can feel like, with your heart racing and with the tightness and with you can't breathe, it can feel like, oh, I think I'm having a heart attack. Remember, those specific symptoms are different. If you do have those specific symptoms that I mentioned, right, where it changes when you're walking, you should go to the ER and see a provider. And of course, the EKG helps to rule things out. EKG and troponins, I think, are the most important, cardiac evaluation you can get, right? What else? Oh, echocardiography. Echocardiography you'll get usually, and it depends on the situation because there's many different complicated indications for an echo, but it's where they take a sonogram. And the sonogram probe looks a little bit like my hand sanitizer thing here, like this, kind of like this, and they'll check on your heart, but it'll be like a big thing, and they'll check here, and they'll check kind of up under your breast, and kind of push up and check there, and they'll look in all these different spots to look at your heart, and what they're doing is they're shooting sound waves into your chest, just shooting some little sound waves into your chest, and then as the sound waves bounce back, it's like an echolocation, kind of like with a bat, and you get a perfect little picture of what is going on in there. And they might do just what's called transthoracic echocardiography, where they look like that, or they'll do this thing where they stick the probe down your esophagus, because your esophagus is right next to your heart, and so if they put the probe down your esophagus, they can see a lot better because it's right next to it. And that's for, if we really have some risk factors, really concerned, depending on how your stress test came back, right? You might want to see that. Exactly. And those things, that's, that some generalists, internal medicine people have special skills in those, but really that's usually a cardiologist doing that. I've met like family medicine or internal medicine people who did the stress tests, but those and who've done quick outside checks of the heart for emergencies, but that thing, or a really detailed sonography, that's usually what the cardiologist does. I've actually never met a non-cardiologist who did that. There may be one, because every physician's training is a little different. So some of us, I have extra training in sexual assault. I got a special training in that, and I have extra training in wilderness medicine. But then my other stuff, I'm a generalist. Same kind of thing. You may have somebody who has a specialty in one thing, but has specialized training in something else as well. Absolutely. Absolutely, absolutely. And it might be that that wasn't their whole residency, like they're family medicine physicians who are phenomenal obstetricians, even though they're not OB-GYNs, because they've delivered so many babies during their family medicine residency or afterwards. Absolutely. It depends. And there are OB-GYNs who don't do any birth, who you know, they did that in residency, they're qualified in it, but now they only want to do gynecology, they only want to do hysterectomies or something like that. So everyone tends to dig into their own thing that they're good at. Yeah. Exactly. And you can a lot of times pick up extra training, even if you weren't like board certified in it. You can pick up small little certifications here and there or extra training by apprenticing with somebody who did have that knowledge. Yep. The dark and wild world of physician certs. So, that's the first group of scary symptoms, is the chest pains. The other thing that we worry about is that lightheadedness while exercising that I was talking about, or that passing out for no reason. That's especially while exercising. Then we worry about a malformation of the heart, especially in a young person. If you have a young person who's ever passed out for no reason while exercising, no apparent reason, that's a big red flag on a sports physical to look into their heart a little more. I see. Did you have anyone in the family who just died for no reason at all and no one knew why? Like at a young age? Okay. Anyone in the family who suddenly had they suddenly drowned even though they could swim, or they suddenly had a single car accident, like they were by themselves and for whatever reason they ran into something? Those again are risk factors for that. That's hypertrophic cardiomyopathy we can talk about. That's that, you know, like there's a malformation. The malformation really is that the walls of the heart are too thick, so it doesn't let enough blood in. Okay. Absolutely. Yeah, unexplained stuff like that. So that's what I mean when I talk about dizziness. I mean, like, you know, you might have had that passing out for no reason, or when you exercise, something might happen. Okay. Yeah, palpitations can be kind of non-specific, but they're important too. Syncope is the big one, the passing out. Okay. And then anyone in your family have diabetes, hypertension, a history of a cardiac, you know, high lipids, hyperlipidemia, or myocardial infarction. Okay. Which relative? Okay. We should definitely do a heart health visit where we talk about prevention. For today, we're almost out of time though, so let's just finish our check. Let me listen to your heart and lungs. I'm going to get you some ibuprofen for that. And what I'll do is I get you this special prescription ibuprofen for your costochondritis. Okay, but we'll listen to your heart and lungs just to make sure we're doing a complete check. Right? Yeah, and you saw I washed my hands right before when we first came in, but have you washed yours? I can give you a little hand sanitizer if you want. There you go. And then you can just rub your hands together. Perfect. Okay. So I'm just going to have you kind of lean back so you're at kind of a 30-degree angle. I'm going to listen in 4 different spots, okay? So I'm going to listen in the aortic spot, and the pulmonary spot, and the left lower sternal border, and down by your mitral valve. Okay. Now what I'd like to do is I'd like you to sit up and lean forward, and I'm going to listen again. Okay. Same 4 spots, the aortic, pulmonary, left lower sternal border, mitral valve. Okay, and that's leaned forward. Now, I'm going to have you lie on your left side. Okay? Okay, go ahead and lie on your left side. And I'm going to have you face the wall. face there. Okay. Alright. I'm gonna listen again, same 4 spots, but this time I'm kind of reaching over you, okay? So kind of reaching over. So same thing, I'm gonna listen. Okay, I know it feels kind of like a hug. Alright, sit back up. Yeah, so it's different. The normal visit, we just listen to heart and lungs, right? Listen to your heart and listen to your lungs. But for a full heart, I want to listen in all these different positions, because these different positions put your heart at different distances from your chest wall, and it highlights different portions, different valves, basically. Okay, so the next thing I'm going to have you do, I want you to sit all the way up here. I'm going to listen to these 4 spots again. When I tell you to, I'd like you to squeeze your hands really hard, okay? Both hands. Yep. Squeeze. Okay. Squeeze. Okay. And squeeze. That changes what's called afterload, because that when you squeeze, it puts pressure on the blood vessels coming out of your heart and pushes that blood back. And so what we're doing is we're seeing, how does your heart pump against that increased pressure, and does that change the sounds? Because that'll change the sounds of some murmurs. Because the little valves that are pushing, they're not pushing, your heart is squeezing to push the blood out, but the little valves, as blood flows through them, if blood is pushing back, it's going to change the sound. Okay, so same thing. This time I want to do something that's called increasing preload, and that's, so your heart is a circuit. Your heart is pumping blood out, and then it comes back around to the body. I want to, instead of increasing the part that comes out, I want to increase the part that comes in, and see what it's like if I'm shooting blood through your heart, right? So to do that, I want you to valsalva, and that means that I want you to bear down like you're going to the bathroom, you know, like you're straining to poop. I want you to do that when I say, or kind of like when they say cough. But don't cough on me, please. Go ahead. Go ahead. Nice. And again. Perfect. Alright, now I'd like you to get up with me and squat. And we're going to listen standing and squatting. Okay? Let's listen standing first, okay? 1 spot. 2nd spot. Perfect. Okay. Now let's have you squat down. Aortic, pulmonary, down here. And now here on this side, just because of the position, can I have you, but just for your own, so it's easier for me to hear, can I have you kind of lift your breast out of the way a little bit? Yep. Depending on the size of the person, sometimes we'll have to do that while they're laying down or in the, but for you, for me a little bit, and then I can get in under on this side and listen without getting in your personal space too much. Perfect. Wonderful. Okay. Alrighty. That's lovely. I'm very happy about that. The other thing that I want to do for cardiac is I would like to listen to your carotids, okay? Do you have any unusual headaches? Okay. So I'm going to listen here to your neck. And then over here the other side. Perfect. Okay. And then I'm going to have you lie back 30 degrees again, and I'm going to look at here. I'm going to look next to your carotids at your jugular vein to see if I see it pulsing in an unusual manner. Okay, other side here. Alright, perfect. Okay, very, very good. And then I want to check all your pulses. The most important thing about these pulses is I'm checking to see if they're different on each side. So I'm checking the pulses at the same time up here on your wrists. And that's right here. A lot of times you'll see people in movies do this wrong. This is like one of my pet peeves. So there's a little divot right here, and that's where your pulse is. It's kind of hard to find. You could try finding it on yourself. It took me most of medical school to be able to find it. I was lucky because I rotated with a vascular surgeon for a little bit, and so he taught me a bunch of little extra vascular tricks. That was really neat. Remember I said different physician experiences lead to different kinds of training and skill. Alright, on your radials. Okay, and they're the same on both sides. And the other thing we check is if they're the same compared to what's going down below, because there are some murmurs where, but it's usually in children, where the flow is different in the top of your body to the bottom of your body because your heart's not strong enough to get it all the way through. Or if it's different on one side, that's... Alright, let's check on the bottom here. Give me just a second. What I'm doing here is I'm checking what's called your dorsalis pedis pulse. It's a pulse right on the top of your foot, kind of in between some of your little, kind of in between your bones. It's very faint, so it can be hard for people to find. And then I also check the anterior tibialis, which is right in front of your ankle. Right? Same thing, checking both at the same time. And then both the anterior tibs. There we go. And these are a little hard always to find. Yours are fairly good. Now you'll see people in the movies always check the carotid because it's the easiest to find, really. I just listen to your carotid, so I don't need to do that. Extra touching. The big thing with the carotid pulse, right? So your carotid runs down here, right? You see people check up here. That's the easiest place to find it, but you're not supposed to check up there, especially not with both hands, because there's two little sensors in your body at that part that can slow your heart rate, and depending on the cardiac condition you have, that could kill you. Or we can actually do a massage there to save your life if you have, something like SVT, supraventricular tachycardia. You can get a massage there to slow it down. You obviously never want to do that with someone who has bradycardia and slow down their heart rate and kill them. So you're really supposed to check down here. And it's supposed to be just one side. And you're looking for this sternocleidomastoid muscle. I've gotten fatter now, so it's harder to see mine. But this is the muscle. This muscle right here. And you're looking underneath that. Sometimes it helps if they turn their head. And then it's easier to find. But obviously, it's always easier up here. You don't really listen from behind. You see people coming in to check from behind. You can't really feel it that way because the sternocleidomastoid is in the way. I see these things in movies and they drive me crazy. But that's how you do it. Well, now I touched myself, so I'm going to sanitize. So you sound good. I'm happy we've checked basically the different functions of your heart at all, various different ranges, right? And we've checked to see how that's affecting your peripheral blood flow. There's two more things I'd like to check, just to see your very peripheral blood flow, right? We checked your heart, then we checked the big vessels, some of the small distant vessels. I'd like to just squeeze your fingertip like this. And this is checking the flow in your tiny, tiny, tiny vessels. And it's more to see how dehydrated or hydrated you are. May I? Okay. Alright, perfect. Anytime it stays uncolored for more than 3 seconds, that's a big concern. You see mine changes color back from white to pink right away. The other thing I want to do is I want to look under your eyelids, like here, in that space. That shouldn't be pale. If that's very pale, you might have anemia. So I touched myself again, so I'm going to go ahead and sanitize again. And then we're going to go ahead and do that on you, okay? Yep. And just look under your eyelids. Okay? What's anemia? Well, anemia is when you have really low. There you go. Perfect, sweetie. You have really not enough of hemoglobin in your blood. You might not have enough iron or some other reason you don't have enough blood cells. Okay. And I also want to check under your, like in your gum. Like if you, I'm not going to touch myself because I have to wash it again. But, like can I have you pull your lip forward for me both? Like that? Perfect. Okay. Yep. You're looking really good. I don't think that you have anemia. Your chest pain, we can always do a blood test if you like. Because you've been kind of tired lately. Well, since you've been tired lately, but you haven't had any of the other alarm symptoms. Let's order CBC. Let's order some vitamin D and a vitamin B12 lab. So now there's not great evidence for ordering vitamin D regularly for when people are fatigued, but it depends on your patient population. And I found in my patient population here in the US, where not a lot of people are always going outside, there is like a lot of vitamin D deficiency, especially in people like if you're a soldier or working class and you're not allowed outside a lot of times because you're working all the time, depending on, because you're working like in a fob or in a thing. It depends on your MOS, obviously, if you're a soldier, because there are some soldiers who are outside all the time. But depending on what your job is, if you have to be inside all the time, so vitamin D can make a big difference. Vitamin B12, but you haven't had any tingling anywhere, right? Okay, we'll check it. It's a cheap test. I have found it to be much less helpful than a vitamin D. Oh, you've been having some emotional as well? Well, we can check a vitamin B6. Let's see if that's covered for you here. So I do have some other visits for depression or emotional health, and then of course you can go to betterhelp.com/drjen to get 10% off online therapy. So that's always a nice option. But you and I can do a more in-depth visit. Yeah, that's an affiliate link. I know, I was really excited to be able to share and promote them, especially during this time. Yeah, that was betterhelp.com/drjen. No, I can't recommend any specific therapist, and I can't do any insurance referral type stuff. That would be illegal, because if you can't insurance refer to somebody and then get a kickback. That's the government doesn't like you because you're stealing from the government, basically. Yeah, so no. But so I can't do that. I can tell you that I think it's really exciting that they have all these different kind of therapists, and so I can affiliate with them. So I like that. Yeah. Or you go to your PCM, your regular PCM, and get a referral to an in-person therapist. And we can do full mental health visits. I have a bunch of them in the playlist, the depression. We need to take some time on that. That's important. Yeah. Okay. So I have those labs ordered, or I've written it down. I'm gonna have you carry the order over to the nurse, and we'll take care of that. That's actually a security risk. I should carry it up for myself. I trust you. Okay. And the CBC is to look at your blood count. Just to see. In the meantime, I want you to eat a lot of leafy greens, dark greens, and then for the costochondritis, what we'll do is we'll get you some ibuprofen, a special prescription strength ibuprofen, okay, that really penetrates that area to help with that. It's going to be a couple more weeks before that heals that inflammation in those chest spaces. And then I'd like you to set up an appointment with me for OMT. Osteopathic manipulation therapy. Sometimes you can have some joints a little bit out of place. Just pop it back in. It's very comfortable. It's kind of like chiropractic. We can look into that. All right, my dear. Thank you for coming and visiting. I hope that this was informative. Sure, if you have any other questions, we can make another visit. It's not a problem. All right. There's so much more. We could do hundreds and hundreds of heart visits. Hundreds and hundreds. All right. Thank you. Yep, right out there. I always love seeing you too. You know what? That actually, now that you mentioned it, right on your way out, you might want to check out the song. Oh yeah, exactly. No, that's not a problem. I don't mind if you interrupt. Yeah, it's been a lot going on, huh? Well, it's that emotional health. You gotta take care of it. I'm sorry that happened. Well, so there was a heart surgeon who tells this story of where, or actually it's another physician who was working with a heart surgeon, and he tells the story of how he saw the heart surgeon do this transplant, and when they put the transplanted heart into the lady's body, the lady did not, the heart didn't start beating like it was supposed to right away. And so the heart surgeon leaned over and told the unconscious lady who's under anesthetic, right, there's some evidence that some kind of subconscious something can hear during anesthetic, but most of the time you would not remember it, you wouldn't know it, right? There's weird evidence on suggestibility, all these different things, blah, blah, blah. Bottom line, in this particular case, this heart surgeon leans over, he whispers in her ear, or he doesn't whisper, he talks loudly, he says, "Lady, you need to tell your heart to beat again. You need to tell it to beat, because the body wasn't starting, the electricity wasn't starting." He said, "You need to tell your heart to beat." And then the heart started beating, it started to take. And the other physician turned to the heart surgeon, he was like, "What?" And the heart surgeon said, "Yes, sometimes they just are like that. Sometimes you have to tell them to make it beat again." And, this is an older heart surgeon with all this experience. I've known a lot of I didn't meet that heart surgeon, but I've known a lot of surgeons personally who've had a lot of interesting experiences like that. I knew a surgeon who, before he would cut, he would always make the sign of the Patriot over there he was going to cut. Obviously, he was very Catholic. I'm not Catholic, but I thought that was lovely. Because he was being so reverent towards this procedure, and treating it like it was a holy or special thing instead of like a cash cow, and I really respected that. So anyway, this heart surgeon story, there's a singer named Danny Gokey, and he made a song about it, and it's called "Tell Your Heart to Beat Again." And based on what you just told me, I think that you should check it out. Yep, "Tell Your Heart to Beat Again" by Danny Gokey. It makes me cry every single time. Alright. Well, have a lovely day. Come back soon.